I've avoided talking about the process of coming up with the idea of the vampire facelift, the O shot, and the Priapus shot, partly because it's personal, partly because it could sound braggart, and I'm mostly a very private introvert. But I do get a lot of questions, a lot of people asking me. Someone else asked me, I was on a phone call with a scientist from Venice, and he asked me where the ideas came from. And so I thought, well, if I took the view of explaining the story, and in the process gave some ideas about innovation. I've been involved with research before medical school. Some ideas about innovation. It might be helpful to someone else, as well as it might give you guys some ideas about how to build upon what we've done so far with these procedures. So here's some of the ideas we'll go over. I'll tell you the story. I'm on purpose. So this is going to be autobiographical because I do have those questions. And from now on, when someone asks me how the idea came about, I'll just refer them um, to this recording. So first, I'll tell you, I started off as a research chemist, and I think that's important because, and this is where I was working, Southern Research Institute in Birmingham, Alabama, do a lot of drug studies. I was a physical chemist, and we were working on things that I can't talk about, but I can say they're helping the world be safer, what we created. And during that time, I came across an idea from my boss. He would send me to the library back in the days when the library was paper and there was no internet back in the 80s. I'm 60, so this was back in the 1980s. And he would say, you have a week to make me an expert, because if you read everything that's been written about a very narrow subject matter, which you can do very quickly, if you narrow the subject matter narrow enough, then you can become an expert. So I would go to a paper library, research things for him, and then from that he would write proposals and we would get money and we would do research. So the that idea came along later in my medical practice. I had been working as an ER doctor, where I started off. I was boarded in internal medicine, but I did work as an emergency room physician, and for a while managed a hyperbaric, this one, Spring Hill Hospital, hyperbaric chamber, where we would manage a lot of wounds. We also treated, of course, diving injuries and necrotizing fasciitis, but mostly diabetic wounds. It's amazing, even though I was in the wound care business, I wasn't really aware of platelet-rich plasma. But when I quit the emergency room and opened up my practice as an internist, I decided that I was going to focus on taking care of women, particularly women around the age of 40, because women around the age of 40, they control medicine. They decide where the children go to the doctor, where the husband goes to the doctor, where everybody goes to the doctor. And so I thought if I could take really good care of that person, that woman, then she would bring the whole family and I would never lack for patients. So even during my years as an emergency room physician, I was studying how to take care of that woman, and actually started doing testosterone pellets before most of the people in the United States were doing them. I had to order the good this was in the year 2000, so 20 years ago. I had to order really good testosterone pellets from Europe, and I had an autoclavable trocar, and A4M was in the early stages. And so I started doing that and then became involved in other research with women's hormones. Growth hormone, I did a phase 4 study worldwide, participated in a worldwide study of genotropin when Pharmacia had that drug. And very quickly, my office was filled with menopausal women for whom I was doing testosterone pellets and other things before Suzanne Summers wrote her first book about hormones. So I had 3,000 menopausal women I was taking care of. Well, here's the other part, and back to the things about innovation. I want you to look at this list again. Innovation often doesn't mean thinking of something new. It means pulling something from one area of science to the other. So before I go on with the story, think about what happened with endoscopic surgery. In the early days, the gynecologists, early days, in the 80s when I was training, the gynecologists were doing endoscopic surgery like crazy, and the general surgeons were not. And it took a Georgia gynecologist to get the idea of becoming very good at taking out, uh, Bill Say is his name. He was taking out gallbladders using endoscopic surgery. So we met and he told me he just thought of it like an adhesion. And he said in the early days he would have to set up at the surgery meetings in the hallway. They would not let him present. Eventually, he built a training center in southern Georgia, south of Atlanta, and trained something like 30,000 doctors to do these procedures. And they would fly from around the world. And he had a farm where they would practice on pigs and then they would barbecue the pigs. But the point I'm making is that you had one specialty, gynecology, that had very much worked out the details of endoscopic surgery to the point they were proficient with it. And the general surgeons were pretty much ignoring the idea. It didn't make them bad people, they just didn't see a need for it. So the same thing happened with platelet-rich plasma. What happened was the um, and I think there's something to be learned about innovation here, in that sometimes you don't have to be that smart if you just look around outside your bubble in other parts of science or other parts of medicine in our case. So what happened was I was doing these hormone replacement with women, and they would lose a lot of weight. And then I had a woman who wanted to quit losing weight, and she disappeared for a while. And she came back and she said, "Okay, I'm ready to lose weight again. I got Restylane in my face." When women lose weight, especially men and women, because the lack of adipocytes or because they get smaller and less in number, their face looks older. Liz Taylor said when a woman reaches 40, she has to choose between her face and her body. And normally, before we had hyaluronic acid fillers, back in her days, she would stay a little bit overweight to keep her face looking young. Anyway, so this woman said, "I got wrestling, now I'm ready to lose weight again." So I thought, oh, well, I should learn to do hyaluronic acid fillers. So I found out who was the top injector in North America, and I went to see him, Dr. Mark Bailey, up in Toronto. Went there a couple of times, studied with him, became proficient. We didn't have Juvederm here in the United States yet, but they had it in Canada. So I learned wrestling, learned Juvederm, came back and started injecting faces. This becomes important later with the vampire facelift. So now I have this knowing about wound care, or at least an interest in wound care, still pretty ignorant to platelet-rich plasma. And I had an interest in women's, especially their hormonal function, and helping the woman who was overweight become more energetic and lose weight. Well, in the process of doing that and giving them testosterone, of course, the sexual part started to come around, and we knew much less about it 20 years ago than we do now. And I found myself becoming a sexual counselor, or counseling women about sex all day long. You really can't do a good consult about hormone replacement or metabolism without, or really internal medicine, in my opinion, without bringing up the idea of sexual function. So, in the process of talking to these women, I realized that we didn't have that much to help them. We had testosterone, but we still don't have a FDA approved women's version of testosterone. Now we have two FDA approved drugs to help women with sex, but both of them just to help libido. So, and back then we had nothing. So, in the process of talking to these women, I became very sensitive to how much sexual pain was not talked about. They would cry in my office almost daily, sometimes several times a day, telling me about how many problems they were having, but they were fearful to talk with their husband about it. So their husband didn't know. They didn't get much sympathy from their friends, so they didn't talk about that too much. Usually it's a flippant answer or an insincere or or unsympathetic answer. They don't talk to their priest or their preacher or their rabbi, and so they go along suffering in silence. Now, here's part of the reason that this happens. If you think about how sexual medicine or sexual problems are unique, the only thing I know that compares to it is psychological problems. Just think about it for a moment. If you have cancer, let's say you have bone cancer, or let's say that you have diabetes, or you break an arm, or you get COVID, in all of those cases, every one of those cases, everything else I know in medicine actually, you might have talk with your family. You might get people to come sign your cast. You might ask your neighbors what they've done about that problem. But if you have major depression and suicide ideation, you keep it a secret from most people. And what would happen if you brought it up? Well, your friend might say, well, I don't understand. You have a wonderful family, a great lifestyle. Why are you depressed? You don't get that much sympathy. Or imagine telling your friend next door that you have schizophrenia and psychosis or bipolar disease and you were psychotic yesterday. So psychological disease is often kept secret. Now, here's the thing that's not thought about so much. Sexual dysfunction is the same. People keep it a secret, often from the people in their own family, because it isn't met with lots of sympathy or wise counsel. And so thankfully it's becoming more talked about, but it's still pretty much taboo. And if you don't believe me, look at the blogs where people bring up their sexual dysfunction, and you'll see many, many insensitive comments, mostly women against other women, saying, well, it's really just, it's heartbreaking. So, so that was a problem, and I became sensitive to it. I didn't realize how many women were not talking about it. But then what happened when I started getting them well, I had another problem. And you'll see this in your practice if you're taking care of people who have sexual problems. If you get the woman well, now she's lost weight, she feels great, she's become sexually active. Then her spouse is going to be in three flavors. If he's been abusing her and she's resentful of that, she's probably going to leave him after she loses her weight, and there's not much I can do about it. If he's very healthy, this would be flavor number two. If he's very healthy and I help her become well, now they come together, they live happily ever after. There's not much left for me to do. The thing that was disturbing to me was the man who was not healthy. Remember, this is 20 years ago, and I would make the woman feel better. And back then, testosterone replacement in men was not as common. And they thought mostly bodybuilders were using it, and doctors are going to jail for prescribing it for bodybuilders 20 years ago. And it was hard to get her to even mention to the husband that maybe he should come see me too, so that I can help him be well. So I'd have women cry that now they feel better, but their sex drive is really high. Their husband can't keep up, but they love him. They don't want to be disrespectful, and so they're not sure what to do. So then I started thinking more deeply about how can we help men, not with just Viagra, because eventually it's not treating the base problem. It's not saying it doesn't help, but Viagra does nothing, as you guys know, for libido, and it does nothing to address the problem of either a venous leak or lack of blood flow to the penis or genital mismatch, which we can talk about later. So I became really, uh, I dove into that again in the same way that I dove into my research when I was a chemist, as in define the area very narrowly, not just erectile dysfunction, but what can we do to help blood flow to the penis that's non-surgical. So, so that was the backdrop. Now, here's where the procedures came along. That was the other backdrop. Well, I'll get to that in a minute. The business model and how business models can help the science. I'll get to that in a second. So here's where, just like you can drag and drop an app on your phone, this was pretty much drag and drop technology to cause these procedures to come around. So after learning to do cosmetic injections to help the women and encourage them to lose weight, I became proficient and became one of the more busy injectors in my town. So about that time, one of the PRP manufacturers brought a kit to market for a cosmetic use. Now here, back to where specialties can be ignorant of each other. This is what was happening. Remember, we talked about how general surgeons were not aware of what gynecologists were doing, at least not aware of it to adopt it. So in the same way, in 2010, when I came up with these procedures, we already had at least 10 years of strong research done by the dentists and the orthopedic surgeons surrounding platelet-rich plasma. Now, this is important because I think it's important to realize it's not, there's the science, but there's also just the common sense. And I think it's needed to stop and think, why were these two specialties thinking about it deeply, but yet gynecologists, plastic surgeons, urologists, and practitioners were not? Simple answer, it was just hard to heal tissue. So for example, I would get patients sent to me in the hyperbaric chamber that were about to have surgery on their jaw, their mandible, and they had had radiation for throat cancer, and now someone has to operate on tissue that was already avascular, and now it's been radiated, and now you have to cut and sew that. Not a good situation. So we do hyperbarics and try to bring oxygen to the area to pre-op and post-op, or help with prevent side effects post-op. So the game that the dentists were playing and the orthopedic surgeons were playing was to see how can you get all the growth factors out of the platelets, the cytokines that recruit stem cells to come to the area. You guys know what PRP is, but it's helpful to think that's what the game was. So there's micropore filters, there's centrifuges that have gels, there's double centrifuges of various technology. But the idea was, how can we get as many platelets and then get the growth factors out of those platelets and activate them in the best way possible? Of course, there's also stem cell research going along at this time, but the stem cell research, it was confusing because the stem cells they're in platelet-rich plasma. So how much is each one doing? So that was the backdrop. So when someone walked into my office with the first centrifuge that was taken out it was being remarketed out of the orthopedic space with a different name to be marketed in the cosmetic space. And when the salesperson walked in my office and said, "Hey, Dr. Reynolds, I see your high volume hyaluronic acid filler injector, and so you should try platelet-rich plasma." And this is what caught my attention. He said it gives new blood flow, new volume, new blood flow and new volume, and there's never been a granuloma or a serious side effect. And I thought, oh, well, that should go in my penis, because I'm thinking we should see. I mean, I'm a man, right? So new volume, new blood flow, and I'm thinking this could be helpful to my patients. But before I try it, I'm going to see how it works in the face. So the face became a model for how I might use it. I hadn't thought about the O shot yet, but I was thinking, how can I use the face and watch what it does and come up with ideas for the penis? So I bought the centrifuge, I treated 5 people, and I did what I normally did with fillers. Now, at that time, they were marketing platelet-rich plasma like Juvederm, and we were being told, use it like Juvederm. The problem is it doesn't not work like a hyaluronic acid filler. In other words, if you sculpt with it, first of all, it's hard to sculpt with because it's aqueous. Second, the shape you make is going to be gone for the most part 2 or 3 days later, and then you have to wait for new tissue to grow. And when it comes back, it won't be in the specific shape that you can't as specifically sculpt with it like you can with an HA filler. So I injected my people and they came back, and about half of them, the younger women, were happy. The other half was telling me, hey, that shape you made went away, so I'm really not happy about that, but my family's telling me my face is glowing. So I thought, okay, well, maybe this might work for erectile dysfunction. Now, at that time, the study had just come out. Oh, I should finish that idea. So while I was doing it, I like to guarantee my work if someone pays me cash. So what I started doing is every time someone told me, well, I like it, but the glow, I like the neovascularization. That's what I'm thinking when they tell me that. But the shape is going away. Then I would take out a hyaluronic acid filler syringe. I usually use Juvederm, and I would put the shape back, and then they would love it. And they would love it more than had I done the Juvederm alone. So I thought, oh, well, I need to think of a name for this. Now, here's the problem, the other problem in how the business can help the science. So think about this for a minute. Injections with HA fillers and the neuromodulators like Botox and Dysport, they're still in the United States not governed by any medical board. So that's not part of, unless something's changed recently that I don't know about. No one's tested on that on their medical boards. And of course, as an ER doctor, I have great respect for plastic surgeons because I've seen them put faces back together that went through windshield and do all sorts of amazing things. But one of the mysteries to me is why there's some propaganda that circulates around that only plastic surgeons should do HA fillers. And then you go to their office and their nurse practitioner or their RN actually does the injections. So the point I'm making from that is that there's not one big governing uh, institutional body that's talking about how we're using HA fillers, which can cause blindness and necrosis of the skin. And I mean, they're reasonably safe compared to many other things, but still, it's not a benign thing to be injecting. And the thing that bothered me back to the business model part of it is that I felt like by studying with one of the best in the world, I had a good start and was doing things in an aesthetically pleasing and very safe way, but I was advertising with the same words that everybody else was advertising. In other words, I was using Juvederm or Botox in my communications, but there's no way to tell because what quality is going to be given from just those words. You can't tell from a board exam, not really. And so to me, it's like advertising beef, and you don't know if you're going to get a gourmet steak or a second-rate hamburger. The sign on the restaurant tells you what you're going to get. You don't just advertise the ingredients. So when I saw, and it bothered me doing cosmetic work, that I had to advertise the ingredients and didn't have a good way to communicate the method or the quality that was being done. So I saw a chance to change that when I came up with the idea of using an HA filler to sculpt a pretty shape and then combining PRP on top of that to bring in neovascularization and make the shape even better. Now, if you go to our Vampire Facelift website, you'll see on the research there 2 papers in the wound care literature where this has been done. You put HA on a wound, it acts as a scaffolding, put PRP on top of it, and the wound heals more quickly and in a more pleasing fashion than if you have either of those alone. And that study's been repeated more fairly recently in a study of children with cleft palate. Um, so, so I didn't know that research at the time. I just knew that when I did the HA first and then put the PRP on top of it, I was getting amazing results, much better than either one alone. And I needed a name to indicate that. Now, at the time, no one had used the word facelift to mean anything other than surgery, so I made a few people angry by doing that. But it wasn't intentional. It just seems to me that truly is a facelift when you're lifting the skin away from the skull back into a more volumetric state that recreates the lifted state of the face when the person was younger, as opposed to actually, if done without thoughtfulness, if you do a quote surgical facelift, you could actually skeletonize the face by collapsing it relative to the skull. Of course, a good plastic surgeon doesn't do that, but the point I'm making is that a filler does do a lift relative to the skull. So called it the vampire facelift, with the vampire word to mean using blood for rejuvenation of life, as in the mythical scary creature. Um, the other thing is that, of course, now vampires are not as scary as they were when I was a kid, when we had Vincent Price and Boris Karloff. Now vampires are beautiful sexual beings, and so it has a different culture code than it did 50 years ago when I was a kid. So it means pretty blood rejuvenating facelift, vampire facelift. And honestly, I didn't expect it to go as viral as it did. I did put a lot of time in it, and when I came up with a name, you could Google that phrase, vampire facelift, in quotation marks, and you got 0 hits, zero, nothing, zero. And but it went crazy. Some people had used the word Dracula, but that's kind of scary. Um, and so it went viral. And but what I haven't talked about is that it was a test for could I control the marketing of an injection for the penis, because that's really what I was thinking. And because I could see it was working in the face, and I was getting up my courage and reading the science about how to make it work in the penis. So in January of 2010, and I was exposed to PRP in early in 2010. So right after this paper came out, the Journal of Sexual Medicine published a paper out of Southern California where they took diabetic rats and they harvested stem cells and then they injected the penis and they documented new endothelial growth and increased nitric oxide in the dorsal nerve. But they also documented that most of the tagged stem cells died. So, and they postulated it was the growth factors that were actually causing the results. So I thought, okay, there's no one's documented PRP in the penis, but looks like it might work. So still hadn't really tried it, but I was by this time using my expertise as a researcher. I had read everything I could find, many, many hundreds of papers about platelet-rich plasma, and couldn't find a serious problem with it. And if you think about it logically, it makes sense. If you have, no one worries about neoplasia or um, something horrible happening from the plasma that is generated when you do surgery or you scrape your knee. We see the plasma as a healing, benign substance that's made and activated by the thrombin cascade. We don't worry about, oh, will I get a neoplasia where I cut myself or where I scrape my knee? Because platelet-rich plasma is made to fight infection and to heal things. So it just makes sense that the research has borne that out over the past 20 years. Anyway, so I eventually convinced myself that it wouldn't hurt me and it was worth a try. The thing that worried me is that injecting PRP in a planar surface, I knew we had deeper blood vessels coming up to the skin, and I didn't have to worry about necrosis. I was worried that if I inject my penis and it turned to platelet-rich fibrin matrix, it might actually cause necrosis or priapism. So it was scary for me, but um, I got up the nerve to do it, and it worked, and I could see things were working better, and the penis was slightly fuller. So I started offering it to my private patients. Still wasn't advertising it. I wanted to do more research, but I started offering it, obviously with a consent form and lots of explaining to my patients. Again, to this day, PRP has a much, much safer profile than HA fillers and just about everything else in medicine. So in the meantime, my sweetheart decided she wanted one. She could see how things were working better for me. And my penis, she thought I actually looked younger. So she wanted it for her vagina. Now here's where pulling in other science helped again. I'd been following the gynecologist and how they had been treating especially Dr. Matlock with his G-shot. The problem, of course, with the G shot is that because it's an HA filler, there's the risk of granuloma. ACOG was coming down on it, and it was more mechanical. But I was following it in great respect for his work. But I was seeing basically it's find the sensitive area in the anterior vaginal wall, put a glob of HA there, so when the penis goes back and forth, it pushes harder on the G spot. So it's mechanical. There's risk of granuloma, and it was never advertised for sexual dysfunction. It was to help normal function be better. But ACOG came down on it. But still, I'm watching it. So when she says, "Well, let me try this," I said, "Well, I've been thinking about it for months anyway, and if you want to try it, we will. Here's what I'm thinking." So the fun thing about PRP is because it's aqueous. Because PRP is aqueous, you don't have to be exact with it. You don't have to make a glob right where the person's sensitive. You just have, but you do have to put it exactly in the right tissue plane. So you can't go too deep with it. You're in the urethra. Too shallow, you're just making a little intradermal bleb. And the other part that isn't known much about me is that I had already published a book years before there was an O shot about how to teach a woman to ejaculate. So I'd followed that research and read in depth about that, and it actually taught my lover to ejaculate. So my thinking was put it in the periurethral space between the urethra and the anterior vaginal wall, hydrodissect the area, and wake up the Skene's glands, and maybe she'll have a stronger orgasm. They're already very strong, but a stronger orgasm, and maybe even a more easy propensity to ejaculate or orgasm. And I thought, while I'm down there, let me inject the body of the clitoris and see if it'll hydrodissect down in the corpus cavernosi along the pubic rami for better function there. So I just used ice, injected her. We went to dinner, and I thought, well, maybe in a few weeks things will get better. But the next day, because of the fluid and the platelet fibrin matrix being there in that space, her sexuality was pretty amazing. Now, not pretty amazing, very amazing. Now, we still don't advertise the O-shot for making normal sex better because it's still sort of not shaky ground, I think, maybe with the powers that be. But because we know from now over 12,000 studies that platelet-rich plasma does cause neovascularization, new nerve growth, new collagen production, adipocytes enlarge and they multiply, it fights infection, there's all this one, and without neoplasia, all these wonderful things. Um, it turns out that that actually happened with her, and that things got healthier. So the next person I called was a person that I had with severe dyspareunia, a woman who had not had comfortable penis and vagina sex for 7 years. This woman had been abused by her husband, previous husband, physically abused in the genitalia and the anus with scarring, dyspareunia, and anorgasmia. She had to use a vibrator forever. She said it was exhausting and wasn't even worth the trouble to have an orgasm. So I had her come in, told her the risk benefits, best I could tell, and injected her areas of pain. Then 4 weeks later, her pain was gone. She wound up reconnecting with a high school lover, and 6 months later, they were married. So, and she's the one that told me that this has stopped my incontinence. Now I'm running again. I've lost weight, feel healthy. I'm not waking up in the night to urinate. So I didn't actually think of that, but my second patient taught it to me. So that's how the procedures came to be. Now, the fun thing is that as I rolled out the procedures and by using the trademark to not anybody can do it. Lots of people learn it from me and go do it or learn it from somewhere else and or just think they know how to do it and ignore the 10 years of experience we have now and just go make up their way of doing it. But we do have people that go to our classes and then wind up doing it on their own. But by using a name now that means doing it in a particular way, using kits that are approved by the FDA, by taking our 10 years of experience, we have such a high safety profile now. We get malpractice through Lloyd's of London. We have a really high safety profile. So So by doing that and using a trademark, we have a way of indicating to patients that that particular standard is being followed, or at least a particular knowledge of how to do it is being followed, which is more than what's done with Juvederm, which is much riskier than PRP. So um, unlike a patent, a trademark can govern who can use the name to advertise. So that's why I chose to do it. And by charging a minimal fee, the other thing that the way that runs off patients is by charging a minimal fee, I can cause people who don't want to pay the fee to go away. Well, often the people who don't want to pay that are less than $100 fee per month are people who aren't doing very many of them, so they start to resent it. And because they resent it, great, they quit using our name. That way some woman doesn't get tricked into going to their office and having an inferior procedure because they happen to see a doctor who has done one in the past year. If the doctor is doing them frequently, they don't mind the monthly fee, and by paying that monthly fee, we're able to then pay very high, pay close to $1 million last year in lawyer fees to run off people who use our name or sue people when I need to, so that people don't get tricked into going to a place where someone just made up their way of doing it. I'll sometimes get an email from a woman who says, "Oh, I had this horrible experience, hurt, didn't help me," and it'll be someone who never trained with us. So that's the reason for the business model. I sacrificed a lot, but I mean, again, I don't want, part of the reason I never talk about this is I don't want to be blowing my horn. But when I realized it was working, after I trained about 30 doctors, they were all telling me it's working. I dropped a lot in my practice and actually dropped my income a lot. Most of the money that comes in still goes out for our employees. I have 10 employees to help handle the people in our group. We have the lawyering, we have research that we finance. But I felt like, well, how many times does a man have a chance to actually be part of a revolution? Now, here's the revolution. Let me stop a minute. Here's the perfect storm revolution we have. One, we're in this cusp where we are still in the process of adapting what was well known in other specialties, PRP, well used, well known in orthopedics and dentistry, and figuring out how to use it in urology, gynecology, and um, and cosmetic uses. So so and it usually takes 20 years for a new innovation to take place. So we're still in the early adopter phase. First heart cath was done in the 1940s. It usually takes 10 years to do the research and then another 10 for it to be widely adopted. And of course, our research, because we don't have a pharmaceutical agent, we're doing research with blood. We don't have millions and millions of dollars to spend because there's no pharmacy to finance it. We're grassroots. So our doctors are either doing research at their expense or our group is paying for research, like our lichen sclerosus studies that we've done. We have a study going on now with one of our urologists out in San Francisco that is costing substantial money, looking at the PRP or our Priapus shot for causing growth of the penis. So I gave up a lot of my practice to do this full time. I still see patients, but I felt like somebody needed to champion it. But here's the social forces that are coming together. So we're pulling the technology of PRP into the space, which gives infinite varieties of things that need to be thought about. For example, washing the platelets has been shown to help, cooling the platelets, drawing the blood after aerobic exercise, infinite ways we could do the injection, amounts to be given, how the platelets are isolated. What else can you mix with it? Exosomes, amnion. Um, does it actually work better with stem cells? No one's done that study. PRP alone versus PRP with stem cells. Probably, but we don't know. So those are some of the infinite varieties of things that need to be looked at, but we're still trying to get enough people's attention, actually have people help us think about it. We have around 2,400 people in our group total. which sounds kind of cool, but it really isn't when you consider there's 35,000 gynecologists in the United States alone, another 20,000 urologists, another 100,000 family practitioner internists who are taking care of vaginas and doing pap smears, another 100,000 physician extenders. So the universe is 300,000 providers in the US alone, and we have 2,300 members. So this is early adopter phase. So this is a revolution, though, because it's not just the science, there's a social revolution, there's a sexual revolution. This came out in one of the news magazines right after 50 Shades of Grey came out. It said the new sex revolution. So in the 60s, it was that it became okay for women to have sex. But the new sex revolution is that it's okay for women to want to have good sex, and whatever that means for them, both physically and psychologically, whatever good sex means to them. So those are two very strong forces where we now have new technologies with radio frequency and laser, and all the innovators in those spaces will tell you that those technologies work better. The gurus, the leaders in that field will tell you those technologies, radio frequency, laser of the vaginal space, it works much better with PRP. Now you notice I never said the word rejuvenation. I just said the word, but the reason I don't use that word is this isn't about just pleasure. It's not just about making something look pretty. Everybody's pretty at every age. This is about function. This is about things working, and not just for pleasure, but for relationships. This is about women not having to be silent anymore when their sex isn't good and being able to speak and demand that their doctor have a conversation. Most research shows that the doctor changes the subject after the first question the woman asks, and only 14% of women ever even ask a question about sex of their physician. That's old data. I haven't seen a recent study about that, but I hope it's changing. I'm not sure it's changing a lot, but that's the revolution. So it's a revolution with new technologies and a new standard. You know, I live in the Bible Belt in Alabama, and when I was a kid, women carried their New Testament in their purse. Some do, but many women did that. Now they carry 50 Shades of Grey around in their purse. So there's this new openness about sex and a new understanding about technologies and a new demand of the FDA that they change the standards so that it's not more difficult, which it is still, to get a drug approved for a woman's sexuality than it is for a man. So I think that's probably enough, but you guys don't need me to teach you what PRP is. I think maybe what's to be thought about is that we need you. This is going to be standard of care eventually. It may go by a different name. It may be done in a different way. I know that our providers in our group are amazing people. We have many urologists, gynecologists, researchers from multiple universities around the world that have thought and made nuances and changes and new ideas. We're now using, of course, the PRP for Peyronie's. I know Dr. Virag over in France published a really good paper showing that it works better um, than Zyflex. We're using it for BXO, lichen sclerosis, dyspareunia, especially trigger point injections and dehiscence of episiotomy scars. Now we have research out about it helping to recover eggs in postmenopausal women. So much to be done. And I think I just wanted to let you guys know where these ideas came from, partly so that you would not think it was something haphazard um, and and not researched and not backed up by lots of research, and partly so, mostly so that you might understand we need you to jump in. If I were offering ways to jump in, I would say get into our group, read all the research, and the best way to take part in research, I think, is what I told you in the beginning. You pick a narrow focus, you read everything that's ever been written, you talk to people that have done it, and then the next thing that pops in your head might be something trash, but it might be something that could be useful. I'll give you if you guys are interested in being our group, I'll put a link right now in the chat box. This is where you can see about, actually, I want to show you a couple of the research papers too. So this is that original study I told you about that really piqued my curiosity about diabetic rats published in Southern California. I just put that link in the chat box. This is a whole page about, this is where we have some of the research about it being helpful in the dermis. One of my favorite studies there is by Dr. Sclafani, where he injected the back of the arm. I'll show you where that study is on here. And then he biopsied the arm and showed that it helped. It's near the bottom down here. So, and then let's see. This is the study by Dr. Varag that showed with imaging studies that PRP works better than Zyflex. Really nice study. I'm not sure why more urologists don't know about that study. And here's where you can learn about joining our group. And we have webinars and journal clubs, and we have teachers around the world. We have online training. And so that's the links to apply for online training. I hope that's helpful. And I know it's a lot of autobiographical stuff there. So I don't know how helpful it was, but there you go. Hope you have a great night and that you'll let me know if you have questions. Oh, I should give you my email. Here it is. All right. Have a great night.